picture this. You have a patient sitting right there in your exam room.
Right.
You're treating them for androgenetic alopecia.
Right.
They're a 32-year-old male. They are 3 months into oral finasteride therapy, taking the standard 1 milligram a day.
Okay. Yeah.
And the appointment is wrapping up. You've done the scalp check. The stabilization looks promising, and you are literally about to reach for the door handle.
Oh, I know exactly where this is going.
Yeah, right. Then they mention, almost as an afterthought, staring at the floor, that they're experiencing some mild sexual side effects.
Yeah. The classic clinical curveball.
Like maybe a slight dip in libido, or, maybe the morning erections just aren't as robust as they used to be.
It happens constantly. I mean, in dermatology, in general practice,
Heck.
it's arguably one of the most challenging moments to navigate in what is otherwise a totally routine follow-up.
Okay, let's unpack this.
Yeah.
Because this is the ultimate doorknob complaint. It's that tricky, highly nuanced issue raised right at the very end of an appointment. And it immediately leaves you, the clinician, standing there wondering, do I stay the course? Do I lower the dose? Do I just abandon the therapy altogether?
Right. It completely changes the dynamic of the visit in a matter of seconds.
Exactly.
Because suddenly you are juggling two entirely different clinical priorities. You have the biological goal, right? Effective hair loss control.
Right, halting the miniaturization.
Exactly. You're trying to halt follicular miniaturization by inhibiting the conversion of testosterone to DHT. That is why the patient is sitting on your exam table. But second, you have the psychological reality.
Your day-to-day life.
Yes, their quality of life and their sexual health.
And as a prescribing physician, you have to balance those two things seamlessly. But before we get into the optimal framework for making that decision, I think we need to look at what most clinicians naturally do in this exact scenario.
Yeah, the gut reaction.
Because there's a very strong default instinct when a patient reports mild side effects at that 3-month mark.
There is. The overwhelmingly common clinical instinct is to just maintain the standard dose, 1 milligram per day.
Just push through.
Exactly. You hear mild sexual side effects at 3 months, and your immediate internal reaction is, let's push through. Let's give the body more time to adapt.
But is that instinct driven by just, clinical inertia? Or is there actually a solid medical foundation for wanting to keep them at that 1 milligram dosage?
Oh, there's a very solid foundation for it. First, the pharmacokinetics and the clinical outcomes of that 1 milligram dose are incredibly well documented.
You know it works.
We know it works to stabilize the hair cycle. And second, from a purely physiological standpoint, 3 months is, it's just the beginning of the therapeutic window for androgenetic alopecia.
Right, because the hair cycle is so slow.
Exactly. The follicles are really just starting to transition from that shedding phase, telogen, back into the active growth phase, anagen.
So you, as the clinician, you're looking at the scalp, seeing the early signs of stabilization, and you're thinking, I finally have the DHT levels suppressed enough to protect the follicle.
Precisely. And clinicians understandably fear that if they stop or reduce the dose prematurely, it's going to trigger a massive shedding event.
Which is the exact opposite of what the patient wants.
Right. You'd be sacrificing the exact therapeutic gains the patient is so desperate to achieve.
Oh.
And on top of that, longitudinal data suggests that in many patients, mild sexual side effects associated with 5-alpha reductase inhibitors can be transient.
They just go away on their own.
Often, yes. The body kind of reaches a new homeostasis and the symptoms resolve without you ever altering the dose.
So it makes total sense on paper. I mean, they came to you terrified of losing their hair. You gave them an inhibitor that's effectively blocking the type 2 5-alpha reductase enzyme, and you just don't want to take your foot off the gas right as the engine is turning over.
That's the mindset, yeah.
But wait, I have to push back here. If the patient's primary stated goal is saving their hair, isn't your duty as a clinician to protect that biological gain at all costs?
Well, I'm going to challenge the phrase "at all costs."
Okay, fair.
Because in medicine, and particularly when you're treating a cosmetic adjacent condition like alopecia, the cost-benefit analysis is entirely subjective to the patient.
Right.
If you push a patient to endure side effects that they find psychologically unacceptable, the cost isn't just their immediate comfort, The cost is the therapeutic alliance.
Meaning they'll just stop taking the pill the minute they leave your office.
Exactly. They will abandon the therapy entirely, often abruptly, and usually without ever telling you.
They just ghost you?
They ghost the clinic. And then what happens? The DHT levels rebound, the follicles miniaturize, and they lose the hair anyway.
So pushing them too hard actually backfires.
Exactly. Protecting the biological gain actually requires finding a systemic strategy that the patient can comfortably live with for decades.
It's like telling a patient with a pebble in their shoe to just keep walking because their pacing is fantastic and they're making great time on the trail.
That is a perfect analogy.
Sure, they're moving forward geographically, but clinically, they're miserable. And they're going to quit the hike eventually.
They absolutely will, even if those sexual side effects are medically categorized as mild. Maybe it's just a 20% reduction in subjective libido. That pebble in the shoe can severely impact medication adherence.
Right.
So the critical decision point you're facing with your hand on that doorknob is whether 3-month mild symptoms justify altering the pharmacology, or if continuing the full dose actually serves their long-term biopsychosocial goals better.
Which means we can't always just tell them to push through the pain. We really need to transition from that gut instinct of staying the course into a rigorous, evidence-based decision framework. So let's look at the official clinical posture. Currently, the recommended default algorithm is still to continue the 1 milligram daily, right? But there's a major caveat regarding how confident we are in that path.
Yeah, there is. The guidelines give this approach a moderate confidence rating.
Just moderate.
Right. We have high confidence in the efficacy. We know the 1 milligram dose reliably improves hair count.
Sure.
But we also have clear evidence that sexual side effects ranging from erectile dysfunction to decreased ejaculate volume are statistically more common with this specific treatment compared to placebo.
So it's a real effect.
It is. The data validates the efficacy, but it simultaneously validates the patient's complaint.
Okay, here's where it gets really interesting. Because when clinicians are faced with a side effect from a systemic medication, I think they often treat dosing like a volume knob on a radio.
Oh, constantly.
Right. The assumption is that if the music is too loud, if the side effects are bothering the patient, you just turn the finasteride dose down from 1 milligram to, say, half a milligram.
Yeah, that's the intuitive leap.
You assume you'll neatly turn down the sexual side effects by 50%, while still keeping enough DHT suppression to maintain a little bit of the hair growth. But human endocrinology doesn't work like a simple linear volume knob.
It absolutely does not. And this is where we hit a massive clinical evidence gap that traps a lot of really well-meaning practitioners.
Because it's so tempting to just have the dose.
It is incredibly tempting. But physiologically, the dose-response curve for finasteride is remarkably flat once you hit a certain threshold.
Let's get into the mechanisms of that. Why exactly is the curve so flat?
Well, finasteride targets the type 2 5-alpha reductase enzyme. At the standard 1 milligram dose, it suppresses serum DHT by roughly 70%.
Okay, 70%.
But if you drop that dose down to 0.2 milligrams, a fifth of the standard dose, it still suppresses serum DHT by almost 60%.
Wait, really?
Yes. The enzyme becomes saturated very quickly at very low doses.
So turning the physical milligram knob down by 80% only changes the hormonal outcome by about 10%.
Exactly. Therefore, we cannot confidently tell a patient that lowering the dose will reliably improve their sexual side effects. The systemic androgen deprivation is largely still happening.
Wow.
Furthermore, we don't have robust data confirming that these microdoses will actually maintain the required tissue-level DHT suppression in the scalp to prevent the miniaturization over the long term.
I have to stop you there, because that is a terrifying trap for a clinician.
It is.
You might lower the dose, effectively lose the hair stabilization at the tissue level, and still have the patient experiencing the exact same sexual side effects because their serum DHT is still suppressed by 60%.
Exactly.
You've engineered the worst of both worlds.
You've compromised the therapy without relieving the adverse event. The dose-response curve for efficacy and the dose-response curve for adverse events are not perfectly mapped out.
Right.
We can't just dial in a customized side effect-free ratio for every individual's unique receptor sensitivity. It doesn't work that way.
Which completely explains why the safest approach, based strictly on the current pharmacological evidence, is to actually continue the standard 1 milligram dose.
Yes.
But you can't just write the refill and wave goodbye. You have to pair that standard dose with really aggressive, prioritized assessment of those side effects.
You shift from passive monitoring to active surveillance. You don't say, keep taking it, see you in 6 months.
Right, that's too long.
Way too long. You say, let's maintain this dose to protect the follicle, but I need you back in this office or on a telehealth call in 4 weeks.
Okay, so a short leash.
Exactly. We are going to track your morning erections, your subjective libido, and your overall mood. You set clear, near-term follow-up parameters.
Okay, so if the default evidence points to staying the course with close monitoring, we need to clearly define the thresholds that require a clinician to abandon that default plan.
Absolutely.
Because you can't stay the course indefinitely if the patient is suffering. What is the specific clinical trigger for deviation?
The primary trigger is when sexual side effects transition from being a mild, transient annoyance to becoming persistent or severe enough to significantly damage their psychological well-being or intimate relationships.
When it really starts impacting their life.
Once it crosses the threshold from noticeable to distressing, you must intervene.
And what are the actual interventions on the table? If we aren't just blindly turning down the volume knob, what do we actually do?
The main options are an intentional dose reduction, such as moving to a topical formulation or an every other day oral regimen, or pausing the systemic treatment entirely.
Okay.
But both of these must be guided by thorough, deeply informed, shared decision-making.
Now, hold on.
Yeah.
If we just established that lowering the oral dose has totally uncertain biological benefits due to that enzyme saturation we talked about, why is dose reduction suddenly a valid clinical option?
It's a great question.
If it's biologically just clinical theater, how can we justify offering it?
And that is the crux of the art of medicine versus the pure science of pharmacology. You are entirely correct that the strictly endocrinological evidence for lowering the dose to resolve the side effect is weak. But medicine isn't just applied biology, it is applied psychology.
Oh, you're saying the intervention is partially treating the patient's anxiety about the drug?
Precisely. A perfectly valid clinical reason to deviate from the standard dose is simply if the patient strongly prefers trying a lower dose to mitigate side effects.
Just giving them that option.
Right. The vital step here is informed consent. They must be counseled that the benefit to their sexual function is biologically uncertain and the risk to their hair is real.
They have to know the stakes.
They do. But if they say, I understand the risks, but I need to feel like I'm taking a tangible step to reduce my systemic exposure to this chemical, you honor that.
Because you are giving them agency.
Yes. Shared decision-making restores the patient's locus of control. Often, sexual side effects have a massive psychogenic overlay.
Right, the anxiety.
The anxiety of taking a drug known to cause erectile dysfunction can literally cause erectile dysfunction.
The mind is powerful.
It really is. Sometimes the mere act of taking control, lowering the dose, and feeling safer is enough to break that psychological feedback loop and alleviate the symptoms, regardless of what the serum DHT levels are doing.
That is a profound way to look at it. You're really treating the entire human, not just the cellular response.
Exactly.
But there have to be hard limits. Are there scenarios where you don't offer a dose tweak, where you have to throw the red flag and just pull the plug entirely?
Oh, absolutely. The red flags require immediate, decisive action. If persistent sexual dysfunction develops, meaning it is not resolving, it is actively worsening, or it's profoundly impacting physical function, or if there is any clinical suspicion whatsoever of post-Finasteride syndrome, dose adjustments are completely insufficient.
Let's define that for the clinicians listening.
Mm.
Post-Finasteride syndrome, or PFS, isn't just a mild dip in libido.
No, not at all. It is a complex, though controversial and not fully understood, constellation of persistent sexual, neurological, and physical symptoms that continue long after the medication has been discontinued. We are talking about severe anhedonia, refractory erectile dysfunction, cognitive fogginess, and severe depressive symptoms.
You definitely can't just play with the milligrams at that point.
Absolutely not. Tinkering with the dose will not resolve those complex systemic issues. That clinical picture requires immediate cessation of the drug and referral to specialists.
Like
Usually urology, endocrinology, or psychiatry. You have to recognize when the adverse event has moved beyond a simple drug reaction and into a complex systemic syndrome.
Right. So recognizing when to deviate clearly depends entirely on who is sitting on the exam table. It's not a one-size-fits-all algorithm at all.
No.
We have to look at the specific patient factors that complicate this entire picture.
You are treating a unique biology and psychology, not a population statistic.
Okay.
And there are two major patient factors that must influence your decision-making right from the initial intake.
Let's go through them. Factor number one.
Factor one is their baseline sexual function and their baseline psychological vulnerability. Patients who start finasteride therapy with pre-existing lower sexual function, maybe they already have occasional performance anxiety or delayed ejaculation, or those who have a history of severe anxiety or clinical depression, they are significantly more prone to experiencing persistent side effects.
Because they simply have less physiological and psychological buffer.
Exactly. A mild physiological change from the 5-alpha reductase inhibition, perhaps just a slight delay in nitric oxide signaling for an erection, can trigger a massive psychogenic cascade in a vulnerable patient.
Right, they panic.
Yes, suddenly a 5% drop in physiological function becomes a 100% loss of functional ability due to that panic.
So what does this all mean for how you initially evaluate the patient before you ever reach for the prescription pad?
It means your initial intake cannot just be a quick look at their hairline with a dermatoscope.
It has to go deeper.
You have to take a comprehensive sexual and psychiatric history. You need to ask, openly and without judgment, about their morning erections, their current libido, and any history of depressive episodes.
Set the baseline.
You must establish a clear baseline. Otherwise, when they complain at month 3, you have nothing to compare it against.
Which leads perfectly into the second major complicating factor,
When?
age.
Yes.
Because if you have a 55-year-old patient coming in complaining of erectile dysfunction on finasteride, trying to untangle the drug's side effects from natural age-related decline is incredibly messy.
Very much so.
It's like trying to figure out which single guitar string is out of tune while a whole rock band is playing at full volume.
I love that analogy because the rock band in this scenario is vascular biology.
Right.
A 55-year-old man naturally has a higher baseline risk of sexual dysfunction independent of finasteride. They likely have some degree of endothelial dysfunction. Maybe they are on a beta blocker for hypertension. Maybe their natural testosterone production is declining.
All those instruments are playing loudly.
Right. So when that patient reports a side effect at month 3, symptom attribution is a diagnostic nightmare. Is it the finasteride? Is it early atherosclerosis? Is it the blood pressure medication? You cannot automatically assume the hair pill is the sole culprit, but you also cannot dismiss the drug's contribution.
It requires a rigorous workup then, checking lipid panels, assessing cardiovascular health, not just blindly stopping the finasteride.
Exactly.
Which brings us to the clinical pitfalls. The things practitioners must absolutely avoid doing when navigating these waters. Let's build out the what not to do list. We've already covered the first one. Do not assume a lower dose magically fixes side effects without harming hair.
Right. The pharmacology simply doesn't support that promise.
Okay, what's next?
The second major pitfall is one we see frequently in the literature review. Do not apply finasteride data from benign prostatic hyperplasia or BPH treatments to hair loss treatments.
I imagine a lot of the really robust long-term safety data for finasteride comes from the urology world treating prostate enlargement, right? But the clinical context is entirely different.
It is a completely different cohort. For BPH, urologists are typically prescribing 5 milligrams of finasteride, 5 times the alopecia dose, to a patient population that is generally over the age of 60. You cannot take the side effect profiles, the severity rates, and the resolution timelines from a 65-year-old prostate patient on 5 milligrams and cleanly map them onto a healthy 30-year-old taking 1 milligram for a receding hairline.
That makes sense.
The baseline vascular health and the receptor saturation dynamics are totally distinct environments.
That is a critical distinction to make when you're quoting risk statistics to a younger patient during informed consent. What's the next pitfall?
Do not rely on arbitrary numeric thresholds or short-term symptom changes to make sweeping decisions.
So,
Don't tell a patient, well, if your libido is still low in exactly 14 days, we'll stop the drug.
because it fluctuates.
Right. Human sexuality is fluid. Symptom fluctuation is totally normal, especially when stress is involved.
You're managing a chronic condition, so you really need to look at the macro trends.
You need to assess the overall trajectory of their quality of life over several weeks or months, not just arbitrary calendar dates. And the final pitfall, which really underpins this entire discussion, never ignore patient preferences or psychological factors.
Right. Telling a deeply anxious patient that the clinical data says you're fine is probably the fastest way to destroy trust.
It is incredibly dismissive and ultimately ineffective. Their psychological reality is actively shaping their clinical reality. If you dismiss their anxiety, you are missing half the pathology.
We've covered a massive amount of clinical ground here, from the psychology of the doorknob complaint to the pharmacokinetics of the volume knob fallacy, right down to the vascular rock band of symptom attribution.
We have.
Let's distill this complex framework into a single, actionable rule. If a clinician listening to this walks into their exam room tomorrow morning, what is the core takeaway?
The central operating principle is this. Continue finasteride at 1 milligram daily to optimize the biological hair outcomes unless persistent or severe sexual side effects arise. If they do, do not panic and do not dismiss them. Consider dose reduction or specialist referral, but only execute those options after close monitoring and thorough, medically honest, shared decision-making.
It all comes down to balancing the biology of the follicle with the psychology of the human.
Precisely.
And it leaves you with a really lingering question to ponder about your own practice. When we are counseling these patients on the risks of finasteride, how much are we inadvertently shaping their clinical outcomes?
That's the big question.
Think about the nocebo effect. There are studies, like the Mondani study, showing that patients explicitly warned about sexual side effects reported those exact side effects at nearly 3 times the rate of patients who were given the drug without the targeted warning.
It's staggering.
By meticulously outlining the risks to secure informed consent, are we unintentionally triggering the very psychogenic erectile dysfunction we're trying to monitor? It's a fascinating paradox to consider the next time you sit down to write that prescription.